Good morning. The offices of the Stephen Lewis Foundation are located on the traditional territory of many nations and is now home to many diverse First Nations, Inuit, and Métis peoples. We acknowledge all Indigenous nations who were, are, and will continue to be in relationship with this territory, traditionally named Toronto. The land that the City of Toronto sits on is included in Treaty 13 and Treaty 13A, signed with the Mississaugas of the Credit First Nation, and the Williams Treaty, signed between the governments of Canada and Ontario and 7 different First Nations communities. The Truth and Reconciliation Commission's 94 calls to action reaffirms that the treaties with Indigenous peoples must be lawfully honored. We are all treaty peoples and are responsible for honoring and upholding these agreements. As an organization, the Stephen Lewis Foundation acknowledges that our presence here is a direct outcome of the settler colonial state whose policies of expulsion from the land and cultural genocide continue to impact Indigenous communities today. The Stephen Lewis Foundation also acknowledges that oppressive and inequitable socioeconomic and political systems in Canada continue to perpetuate this legacy of racism, intergenerational trauma, and structural inequality, and that this legacy is directly linked to the disproportionate impact of HIV on Indigenous communities within Canada. The Stephen Lewis Foundation is committed to the principles of social justice, equality, and solidarity with our African community-based partners as they face the continued effects of the HIV and AIDS pandemic in sub-Saharan Africa. Consistent with those values, the SLF commits to a journey of ongoing learning, reflection, relationship building, and solidarity with Indigenous communities in Canada. Thank you.
Thank you very much for that, Niambi. In a moment, I'll hand the reins over to Josephine and our panel to introduce themselves and get the discussion going. But just in the interest of making a few housekeeping remarks before we get started, I want to let you know that if you have any technical issues or concerns today, please feel free to use the chat function to send a message directly to us, and one of our team will assist you. You might see already there are some messages from us in the chat. At the end of the panel, there will be a Q&A. If you have questions for the participants, please submit those through the Q&A function, which you can find at the bottom of the screen if you're using a computer, and perhaps at the top of the screen if you're logging in using a mobile device or an iPad or tablet. A recording of today's webinar will also be available after the event, and you'll receive that recording link in an email that you'll receive to the email that you used to register for the webinar today. Finally, we do invite you to participate in today's discussion through the chat. So please feel free to share where you are from, where you're joining us from, and include your reactions and input to the related discussion. Thank you, and I'm going to hand everything over to Josephine and our panelists.
Thank you, Alana, and welcome everyone. Thank you for joining us for this event today. I would now like to introduce our panelists, Dr. Nancy Edwards and Kiswahi Dalmini. And each of them will introduce themselves, and then we'll get into the interesting discussion. Nancy.
Thanks very much, Josephine. I'm a community health nurse and an epidemiologist. I'm now retired and a professor emeritus at the University of Ottawa. I've worked in the field of global health for almost 40 years, most of my career. And I'll just add that I'm a proud grandmother of a 2-year-old grandson who lives nearby.
Thank you, Nancy. Kiswahi. You are muted. You're on mute.
Thank you. Hello, everyone. Thank you, Josephine, for this moment. My name is Kiswahi Dalmini from the Kingdom of Eswatini. I am a nurse midwife with a general nursing, midwifery, and masters in nursing science. I work as a nurse midwife and as a programs coordinator at the Eswatini Wellness Center for healthcare workers and their immediate families. Thank you.
Thank you. And I'm Josephine Etowa from the University of Ottawa School of Nursing, where I had the opportunity to work with Nancy for many years. In fact, she was my postdoc supervisor. That's how I ended up at the University of Ottawa. And I'm just delighted to hear her speak about her experience visiting Africa and the impact that has had in her career. So Nancy, let me start by just asking you, could you please tell us about your book and what made you want to write a book about your experience working alongside traditional birth attendants in Sierra Leone?
Well, maybe I'll just give you a quick overview of the book to start, and I'll finish off with a poem that was a big part of describes the inspiration to write it. The book really begins with my experience as a community health nurse and nurse educator in Sierra Leone. I worked among the Mende people in a very rural area of the southern province of the country. The Mende were very proud, very resilient, great sense of humor, and really engaging storytellers. I learned a tremendous amount from them. They taught me about their traditions and culture, the power of ancestors, and the many, many ways in which people can advocate for health improvements. What I learned during my 5 years in the country really shaped both my life and my research career. When I first arrived, I was taken under the wing of a Holy Rosary sister who ran Sarabu Hospital. Her name was Sister Hilary Lyons, and really she kind of provides the bookends for my book. She was the first person that I met when I arrived in Sarabu, and I visited with her in Dublin in the fall of 2019, just before COVID, when we spent some time reminiscing about our experiences in that country. I worked very closely with community health workers and especially traditional birth attendants who were really played a very pivotal role in primary health care in the country. I was involved in helping to train them, and I would say they were training me at the same time and evaluating some of the programs that were set up for them. They were really entry points for much of our community health work and an extremely important cadre of community health workers. Retirement and COVID both really gave me the time I needed to reflect on my experiences and write the book. And I kept thinking back to an older woman, a Mende woman I met in my early years of being in the country, who spoke about her many losses. And I captured that conversation in a poem, which is at the beginning of the book. So with your permission, Joe, I'd like to read that. It's called Not One, Not Even One. So I've already told you where the title comes from. An African Mende village where Ngewo, God, gives and takes, rainforest provides and threatens, farming feeds and starves, children bring lifetimes of promise or sorrow, and childbearing is the lifeline to social security. Nurses, midwives, dispensers, and doctors in barely accessible clinics, health centers, and hospitals promise treatment and services that frighten and cost and displace. Dislocating villagers from Maori men, traditional birth attendants, and ancestors who are trusted to heal and protect and appease. Nurses squat on cane stools, asking women about reproductive histories, for precise numbers, for robust indicators, for efficient measures of public health impact. Standard questions cut through women's stories to the nub of births and deaths and causes and dates and ages. An elder edges forward, deep wrinkles, gnarled fingers, a halting gait. Mama is outside our bandwidth of childbearing years. Propelled by determination, resolute for an interview, she will add her history to public health records. Mama sits, bold and deliberate, Eye to eye with this foreigner, translation begins. Mama, how many pregnancies? 12. Mama, how many were born alive? Her voice catches. 7. My inquiry softens. Mama, how many lived to the age of 5? Tears well, shoulders slump, memories flood. None, she whispers. Not one child lives, not even one. Turning away, she chants, a day to God, it is up to God, wrapping herself in fatalism, quelling grief. My words can't console, my words can't express, my words can't talk. Her story renders my words empty and superfluous. In emotive silence, we clutch hands and hearts, women bridging and feeling and connecting across our cultural divide. Her shared story, her only memory keeper of lost unborns and newborns. Mama's imparted narrative of losses and sorrow and heartbreak and grief and fatalism, now seared deep within me. Decades since this encounter, I am beholden to this courageous Mende woman, to amplify her story through worldly connections, to impart the despair of her losses, to bolster access to safe care, to prevent tragic scenarios of not one, not even one.
Thank you, Nancy. Kiswahi, I'll now go to you to follow that. So, given your experience, how has maternal health care and birthing support changed in Swatini since you became a midwife? And what do you do in your role to advance that work?
Thank you. I have been a midwife since I did my midwifery in 1997, 98. That is when I graduated as a midwife and I started working as a midwife. So the changes that I have seen is women are encouraged to plan their pregnancies. Like Nancy has just said, women can deliver up to 12 or even 15 children. But now with ongoing education, the women are now encouraged to plan their pregnancies so that they even space their children in a way that will be healthier for them and even the children. So another change that we have noted is that of men involvement. Men involvement in maternity and birthing. When we started nursing, it was rare to find men accompanying women to antenatal care, not even talking about to the labor ward. So slowly, men involvement is improving. Another change that we have noted, women are now enlightened towards having fewer children, which also assists in decreasing maternal and infant mortality. And postnatal care has been, postnatal care is now available in our hospitals. We encourage women after delivery to come for postnatal care within the first 7 days, first 3 to 7 days, after 2 weeks, and then we continue up to 6 weeks. Otherwise, when we started, women were coming at 6 weeks for immunization, but now they're able to come even before then, so that problems are noted early before we lose the children, because we were losing children between birth and 6 weeks, or when they come at 6 weeks, it's late. And another change that we have noted is the use of traditional concoctions. Because we are Africans, we use traditional concoctions. So the use of traditional concoctions to hasten labor progress has gone down, which also has seen our women progressing maybe I can say naturally or even assisted with Western medication if they have problems. So this also has seen our maternal mortality and infant mortality going down somehow. Thank you.
Joe, you're muted.
Sorry, I'm talking to myself. Please, can you tell me more about the work of the Swatini Nurses Association in increasing these interventional strategies that you've just described for us?
Okay.
Your
The
Nurses Association.
Yes, the Nurses Association, they came up with, they are the mother to the Eswatini Wellness Center, which caters for healthcare workers and their family members. They had the thought that if we will take care of the healthcare worker will be better able to take care of the people that they are taking care of, especially the nation. So that is what the Nurses Association has done. And also what is happening is also the nurses are being educated on how to take care. They are even encouraged to attend to updates and other necessary information that will make it necessary for them to improve in maternal and infant mortality in their working. So the Nurses Association is their brainchild. The Wellness Center is doing quite well in taking care of the healthcare workers in the country.
Thank you very much. Nancy, I'll bring it back to you. In your experience in Sierra Leone, what role did birth attendants play, and what difference did they make when they attended birth?
Well, maybe first I'll just say it's very encouraging to hear Kiswahi's description of some of the improvements and changes that have happened in her country. And I think throughout Africa, you know, that is the case. I went to Sierra Leone in 1978 and I worked there until 1984. At that time, the traditional birth attendants in our area actually did about 90% of all births. Our cesarean section rate was something like 0.1% compared to 20 to 30% in Canada. They were members of the Women's Secret Society, so they really held two roles which were really important, both highly trusted, highly respected roles in their society. And the link of the traditional birth attendants and their role in the Women's Secret Society was pivotal to how they were able to work with the women and how they were really esteemed in that society. There was a lot of trust for them, of course, and it was known that they had the best interests of women and families and the community at heart. And they were the ones who lived in the community. So, after a birth, everybody knew what had happened, and they lived with the results just as the family did. They were involved in and encouraged to refer high-risk women to a health facility where there was a trained birth attendant. So they had a very important liaison function between the villages and the health facilities, but things didn't always go as planned, in part because although the traditional birth attendants were being trained, sometimes the hospital professionals had not been trained about the importance of their role. They only have had their experience in hospitals and didn't understand the pivotal role that they played when things went awry with a pregnancy or during childbirth. And maybe I'll just read a short anecdote, which is a traditional birth attendant who had training, and she had actually accompanied a woman to hospital, and this is her description of the experience, which did not go well. She had brought a woman who had been in labor for 2 days to the government hospital for admission. This traditional birth attendant had spent long hours attending the woman and a sleepless night persuading the patient's husband to let his wife go to hospital. He had relented on one condition. The traditional midwife, the provider he trusted, had to stay with his wife throughout her hospitalization. The charge nurse and staff midwife had shown the TBA a total lack of respect when she arrived with the laboring woman at the hospital entrance. They shouted at her, asking why she had waited so long. They had not even given her a chance to explain the legitimate reason for the delay. Instead, the nurse and midwife made disparaging remarks and banished the traditional birth attendant from the hospital and from the patient who was in her care. This granny midwife had been forced to break her promise to the woman and her husband. The confrontation threatened to fracture her relationship with the community. When she spoke to me, she was still feeling wretched about the whole affair. So these were the kinds of issues that we really had to work hard on, both with the traditional birth attendants and the women and their families and the healthcare providers, to make sure that there was a seamlessness and a common understanding to what their respective roles were, and how that woman would never have got to hospital at all had that traditional birth attendant not been involved, because the husband would not have given permission for her to go.
Wow, Nancy, that's a powerful example. Thank you. Kiswahi, I'll come back to you. What are the biggest barriers for women who want to access proper perinatal care, whether we're talking about antenatal, during birthing, and postnatal care?
The biggest barriers that women face in perinatal care are financial barriers. Most of our women are not working. So some depend on the male partners or even their families. So that is one of the barriers that they have. It's financial. They also have, some have poor support, a poor support system, because we have a large number of single parents who get pregnant and go through the perinatal system. And then another barrier would be proximity of healthcare institutions and clinics. As we know, our country, Eswatini, the landscape is sort of mountainous mostly. So we have health facilities that are not situated close to where these people are or where these people live. Some of them even deliver along the way to hospital. Some of them choose to deliver at home because some don't even think of going to hospital. But we have seen that one also reducing as people are being educated on birth preparedness. Another barrier would be the level of education. The level of education. Yes, our country is improving, with everyone encouraged to have basic education, but that level, we still have those women who are not well educated, who have less than the basic education that is necessary. So that also gives them a problem, because it is hard for them to access care and services, because most of these things are written down. We even have some places where the language barrier is a problem, but usually most of the hospitals have people who speak the native language. Those are the barriers that I can talk about for today.
Thank you so much. I just want to take a minute to remind everyone, just post your questions on the chat box, because we will give some time at the end for those questions to be addressed. So keep the questions coming, and we will read them out to Nancy and Kiswahi at the end of their discussion with us. So Nancy, I'm coming back to you. Actually, I talked about the birth attendants. And now I think actually I would go back to Kiswahi again.
Yes.
So in your experience in Sierra Leone, what difference did the local birth attendants make for a mother and a newborn baby? Is that the one?
I think that's probably for me since it's about Sierra Leone.
Yes.
Yes, great. And Kiswahi, I can certainly relate to those barriers you're talking about. In our area, illiteracy was a really big challenge. Most of the population were illiterate. It was about 95% when I lived there. And even today, I was looking at some recent data. I think they estimate that in the rural areas, 2/3 of women are illiterate. So there have been strides made with basic education, but there are many challenges. And one actually that I was recently reading about is that, and this was true when I was in the country, if a teenager became pregnant while she was in secondary school, she was no longer allowed to attend school. And they've tried to reverse that policy and so on, but it, probably means that, you could argue that those who most need the education are not allowed to continue with their schooling. But back to your question, Joe, about what kind of difference traditional birth attendants and community health workers made in the country. We had very, very high rates of maternal mortality, infant mortality, neonatal mortality, and so on in the country. And maybe I'll use the example of neonatal tetanus to illustrate this. I mean, when I went to Sierra Leone, I had never heard of or seen a case of neonatal tetanus. But in the area where I worked, 25% of all infant deaths were due to neonatal tetanus. And it's a horrible, cruel disease that kills very quickly. And even with treatment, which most children were not able to get, the survival rates are extremely low. And as we all know, because we've all had tetanus toxoid, it is a completely preventable disease. So this was something that we thought was really important to tackle because it was, sort of low-hanging fruit in a sense, and we could really do something about it, especially as immunization programs were being introduced. And we talked to everybody about it, all the community health workers, and they would talk to the chiefs, and we would talk in any home visit. We would discuss tetanus toxoid immunization for pregnant women. In our health education sessions with school teachers, we kind of considered everybody in a sense to be a community health worker, a community health communicator. But it still felt like the neonatal tetanus problem was owned by Sarabu Hospital's public health team. We were still the ones kind of, leading the clinics and so on. And it didn't really feel quite like our traditional birth attendants had taken it on. But I can still remember the day I was teaching in the classroom and it was really hot. The windows were open. This breeze was wafting over me. I can feel it even as I speak now. And we heard the singing on the hospital compound. And it was actually our local traditional birth attendants who were leaders of the secret society, leading some new teen initiates across the hospital compound. And they had come to tell us something. So we gathered around our public health team. And what they told us is that tetanus toxoid immunization henceforth was going to be part of their initiation practices. And it was just such an exciting moment. They now were leading this. And there's nothing that could compare really to that strategy that they had come up with themselves and decided that this was just going to be part of every initiate's initiation. And since essentially 100% of women went through an initiation process and the education that went with it and so on, it was like 100% coverage, at the flick of the fingers. So that one has really stuck with me. There are, of course, many other examples, and I talk about some of them in the book. But overall, changes, we could see that changes were starting to come, and training programs and understanding how to train through the use of song, for example, as opposed to a more traditional lecture, using drama for education that just engaged the entire community in a discussion about a health issue, trying to find ways to support the community health workers in their messaging, and making sure that people understood that they were credible health workers were all critically important, I think, to their successes.
Thank you, Nancy. And that wonderful illustration, I can just picture the women singing, and it just brings back memory from my own community health work in Nigeria. When you talked about the singing, I just thought about when diarrhea became such a big problem, and the oral rehydration therapy, ORT, I was trying to remember the initial. We had to start singing song about this. It became like school song that children go home to sing to their parents. So thank you for bringing that memory home.
Yes, I used to talk about child-to-child programs in Kiswahi. I don't know if you have those in your country, but where, just as Joe has said, the children would learn the songs in school, and then they would, be singing them at home and passing the message on from child to parent. So that was really interesting to see.
Yes. Okay, I'll go back to you, Kiswahi. So when you are providing care to pregnant people, how do midwives like yourselves, nurses, and community health workers address the complexity of the HIV pandemic? We're bringing it back to HIV, tying it in. Our host is the Stephen Lewis Foundation, so we have to bring it back to our area.
Yeah, thank you. And thank you to Stephen Lewis Foundation for even supporting the Wellness Center. The HIV pandemic has hit us hard in our country, but gradually we are improving. We're getting up from that blow of HIV. So the healthcare workers, I just call them healthcare workers, because we used to have traditional birth attendants when I was still a student nurse. I remember one time when I was just after graduation, I was working in maternity labor ward. I was asked to go and present to the traditional birth attendants in one community on labor progress, how to identify if there are problems, emergency preparedness for them. But eventually they were not promoted. I don't know if they are still there in the country, but we have rural health motivators. In every community, there are women who are taking care of the health needs of the community. Each one is given an area that she will look and attend to. She visits the people, notices if there are problems, and then those people are the people that we can work with. The nurses in the health facilities work with the tradition, these health motivators in the rural communities. So what we do concerning HIV, the communities, everyone is educated on HIV, and the women are encouraged to know their status. We encourage women to know their status, and preferably before pregnancy. That is where prenatal comes in, before pregnancy. And then if a woman comes for antenatal care in a clinic, the first visit, it is mandatory to perform a HIV test, just to know what status of the woman is. And then we started this treatment as prevention. We start these women on lifelong ART as prevention. So it helps to prevent the mother-to-child transmission to the child. So that is what we do concerning HIV. And even the health motivators are even taught on, as they take care of these women who find themselves not being able to reach hospital, maybe delivering at home. These health motivators are educated on how to best take care of those women and encourage them to attend postnatal care within the first 3 to 7 days. Those who have delivered at home, they're encouraged to go to hospital for the first postnatal visit within 3 days of delivery.
Thank you. for that. I like the idea of the health motivators. So do they address only maternal child health issues, or do they cover other areas? Like you said, they talk about HIV, but what other areas do they cover?
Health motivators, thank you, Josephine. Health motivators talk about all health issues, all health issues. Now that it was COVID, they were talking about COVID, they talk about diarrhea, they talk about malaria, they talk about all health issues.
Okay.
Yes, it's just that today we're talking about maternal health issues.
Yes. No, it's a neat concept. Thank you so much.
Yes.
Nancy, I know you've given us some great examples, and you've given us so much more in the book. I want to give you one more opportunity to think about other examples you want to share with us here. We have nearly 80 people online from your book as you wrap up. That would be my final question.
Maybe the one I'll share, and there are so many, but it's one where I think it really hit home to me how challenging it was for pregnant women to get to hospital. I was out with my students, and we were in an area where I didn't normally work, but there was a Methodist hospital there. And we were heading out to some villages to do a community assessment. And I can remember looking at the map just to get a sense of, where we were heading, and it looked like it would be sort of maybe 20 minutes away or so as the crow flies. Well, we got into a passenger vehicle, and that was a half hour or so lorry ride in the back of a truck. And then we got down from there, and then we walked for 3 miles through swamp rice farms beside a river. And then we had no boat with us, of course. We weren't going to swim with the crocodiles. So we actually had to wait until we saw somebody in a dugout canoe, and we hollered for him. One of my very nimble female students, she was a lightweight in her group, so she climbed a tree and hollered for the boatman to come over, and he came and got us. So, that was another half hour or so. Crossed the river in the boat, landed in another village, and then we had another mile or so to walk into the village we were going to. So I started to think, if a woman in this village has a postpartum hemorrhage in the middle of the night, she has zero chance of getting to that hospital that looks like it's 20 minutes away. And that is just the reality for so many people in many African countries and other countries as well. There isn't a transportation network, nor can you even imagine how you would set up the transportation network in these communities. So the traditional birth attendants in that instance don't know some of the basics, even like, massaging the fundus to try to reduce the bleeding and so on. Women will hemorrhage to death, literally. So I think it was probably a lot of those stark realities that I experienced that helped me understand in new ways what it meant when we talked about simply referring a woman to hospital, like, she needs care, get her there, right? But it's just not so simple.
Yeah, absolutely. Thank you, Nancy. Very powerful indeed. Kiswahi, can I, listening to Nancy talk about this, especially this last example she's just given, have you seen a change? Has that advanced? And if so, based on all the work you're doing with the Nurses Association, where are you now? If you were to just give us an illustration to just wrap up what Nancy just shared.
Thank you. I have just noted a shift. It is not a very big change, but it is a shift because we are slowly, gradually shifting from what was happening back then, and we are gradually improving. Now that in Eswatini, we also have transport that is provided by, which is a phone call away. You can call and call for the ambulance, then they come and take you to hospital. But most women, instead of planning about transport, you find them, they wait to call the ambulance. And one woman, they called me, I went to see a young girl who had delivered, and the placenta was not completely or fully delivered. She had delivered the previous day, at 10 a.m. waiting for the ambulance. And somebody happened to know that I was a nurse staying nearby. So they came early in the morning, they called me. I had to go and assist her to deliver the placenta. She was still waiting for the ambulance to come and collect her. So we are seeing a shift, but we are not yet there. I can't say we are not yet there. It is just a shift. People are being informed on birth preparedness planning, or even family planning and other issues pertaining to maternal health. Thank you.
Thank you, Ketsua. Okay, I think at this point, I see Lana's camera is on, so I would pass it on to Alana so we can answer some of the questions that we already have waiting. Thank you, Nancy and Kiswahi.
Thank you all. Yes, we've got some very interesting questions coming in on the Q&A and the chat. So again, to our attendees, please feel free to put your questions in the Q&A. But our first question is, what are some of the more recent lower cost and creative or innovative solutions that you have seen implemented either locally or that have been included elsewhere that may be applicable to the situation here? And I guess they mean help improve maternal and birthing health. Perhaps Nancy, you could speak to this, and maybe we'll get Kiswahi also to speak a little bit about some local low-cost solutions.
Sure. So I'll mention it, maybe just two or three quick examples. I mean, Josephine actually mentioned one, which is oral rehydration therapy, which is hugely cost effective. You know, you need water, salt, and sugar. That's it. But it can save the life of dehydrated children and infants quickly. It's quite remarkable to watch how they revive after they get oral rehydration solution. In Sierra Leone, they have, I mentioned the policy that existed around, at least informally, that teen girls who were attending secondary school would have to stop their schooling. And actually the government introduced a program just before Ebola, which would allow the students to continue their education, but through sort of out of the classroom, continuing education for them, but they wouldn't have to drop their secondary education altogether, which was what they had to do in the past. Now I believe they are now integrated into the classrooms if they're pregnant, and I just think that's so important in terms of maternal education. And in Sierra Leone, actually, traditional birth attendants were banned from doing deliveries in 2012. There's quite a bit written about that if some of you are interested. Pros and cons for sure. Other countries have done this as well. Malawi banned TBAs and in fact then revoked that ban after some years, but they have tried to engage them in still a lot of community health work as community health workers. So they get training and they do a lot of the liaison, teaching of pregnant women, encouraging them to get a delivery in a healthcare facility and so on. But you know, babies come when babies come. So I'm a bit on the fence about this myself, because I think the traditional birth attendants will continue to practice deliveries to some extent, because what do you do when the mother is about to birth and you're 10 miles from a hospital?
Thanks for that, Nancy. Kiswahi, do you want to weigh in on some low cost or innovative solutions that you've seen in Eswatini?
Yes, in Eswatini, we do have outreach services whereby the nurses in the clinics, they go to where the people are, the different places. Like we say, some of these places are far from the health facility. So the nurses go and provide services. They bring the services to the people. And usually when they bring those services, the people do not pay for those. And we also have other organizations like the Look Commission, which also visits the different places, these awkward places, these hard to reach places, to offer these services free of charge to the people, including maternal and child health care and other healthcare services. Another thing, we have subsidized healthcare services in our government clinics and hospitals. You pay very little compared to what it would cost if you went to a private facility. So it's subsidized. Antenatal care, family planning, you pay very little to get those. And also, as for antiretroviral therapy or treatment, that one you get for free, and even TB free. And for antiretroviral therapy, you can get up to 3 to 6 months supply, so that people do not travel every month. That also helps them even if they are working, and also helps them even if they are not, they are staying at home, so that they will not have to be traveling these very long distances to the healthcare facility. But we also have these people whom we need to see every now and then. So some of these organizations, they help, like the Look Commission, they give the clients money for coming and going back. So when they come, they have money. When they go back, they even get money so that they'll be able to come during the next visit. Thank you.
Thank you for that, Kiswahi and Nancy. We have a great question that's just come in from Nola. So I want to, I think it's a short one and a good one. And she's asking, are young males, whether they are fathers or just in general, involved in any programs of awareness or support? Kiswahi, maybe you could answer that with your experience in Eswatini. What's the level of involvement of men in this work?
Eswatini is encouraging male involvement in health services. So in such a way that in some clinics, when a male comes to the hospital or maybe accompanies the woman to maternal health services, they don't even have to queue. They jump the line because there's a male. They are being encouraged to come to the hospital, because men, they get tired of waiting. So they are not kept waiting. If there's a male, they are allowed to come in. And we also have other organizations that are looking specifically at men issues and encouraging them to be involved in healthcare for their families.
That's great. Thanks. Nancy, did you want to weigh in there?
Yeah, sure. That's such an interesting example. Moving the men up the line. Terrific. And one of those universal phenomena about men, I guess. But that aside, in Sierra Leone, in the area where I worked, birthing was considered entirely women's business. So in fact, even if women would talk in the community about birthing, they normally did it in the secret society areas, and the children would be banished, and men would never venture into that area. But matters of pregnancy and a referral to a hospital and postpartum care and so on, that was all okay to talk about it. And most of my students, in fact, were males, but it was only the females who did midwifery. But there were many efforts to engage, maybe not in the way we might think about it in the West of, having men present in the delivery room and so on. That was just not done. But in terms of supporting the women, having the discussion about whether or not the woman needed to deliver in hospital, as Kiswahi was saying, having a plan ahead of time for high-risk women. So you're not talking about calling the ambulance at the last minute. All of that required a high level of engagement of men.
Might just add a little bit?
Yeah, of course.
Sure. Yes, I just want to add to what Nancy just said about how men were engaged. working in the community and sometimes working with the chief, they brought men to actually mobilize resources because they would hear of the stories happening at the health center. And I remember one village I worked in, and the men mobilized and started harvesting palm nuts, and they would sell this enough to be able to help us have a betting room. They actually generated enough income to build this, which helped us advocate for more staff at the center, but also helping with transportation. They would arrange for local people who have a bike and other means of transportation, so the chief can let people know to be available to provide support if needed based on that. So they provided that kind of support, not so much coming to the.
Yeah, those are great examples.
Yeah, thank you all for those examples. And what a great question. Josephine, I'd like to ask you this next question because I believe it's in line with the research and work that you've done, but what impact does race have on a woman's ability to access health services when it comes to pregnancy and birthing?
Are we talking in Canada or in Nigeria?
I think you can speak to both. I think it would be great. We have a lot of people joining us. I see from the intros, a lot of people in Canada. I'm sure they would love to know that context as well.
Oh, okay, all right. Because most of my research around race and the impact of race on healthcare access is more Canadian based. But yes, even in Africa, we talk about tribe and tribalism and how it affects access to issues, but also cultural context. And so in my experience working in rural communities in Nigeria, yes, a culture does have impact on childbirth. But the whole process of childbirth, even what you do with the umbilical cord and what you do with the placenta are all culturally influenced. And so women come in with some values that drive even who they will listen to. And the example Nancy gave about the traditional birth attendants that took that woman to the hospital, there's a level of understanding there, even in terms of the cultural values of a senior person who would be there, this traditional birth attendant. And when she goes to the hospital, she's expecting that person who understands that culture and who she can relate to be there with her. And so coping and the resource to just even withstand the labor pain is influenced by all of that. And when it's taken away from you and you're at the hospital where the nurses and doctors may not be so understanding, it does impact on the progress of labor and even other complications that can occur. That's for here in the Canadian context, having worked in the perinatal healthcare system for many years in Canada, and done studies to look at this access. Yes, race does impact on healthcare, including perinatal healthcare. And when women go in and feel like their needs are not understood, that people don't understand their particular issue, it can be as basic as having an intravenous infusion started on you, and sometimes the healthcare provider not knowing how to palpate your vein because the skin looked darker, and being even nervous. Oh, I can't find the vein. Well, you're not supposed to find, you're supposed to palpate, right? Things like that I've talked about in my study, or even just how to assess even good circulation in the newborn. The APGAR score we talk about in newborn, when a baby is born at 1 minute of age, we assess good circulation in the baby through skin color and other things. Well, the dark-skinned baby does not look pink at birth. And so when we use pink as an indicator to mark a healthy baby, the newborn Black baby at 1 minute of age is already marginalized and not being assessed properly because they may give you 2. When you're supposed to, or not give you points in that APGAR score because you don't look pink and you're not supposed to look pink. And so we're changing that in training programs, hopefully, and hopefully even assessment of things like jaundice in newborn baby or just anemia in Black skinned people. we're doing better in assessing them. So there are many ways in which access to care is compromised. Even though we have universal healthcare system in Canada, it does not guarantee access to everyone and equal access. So that's why the inequity and EDI programs that are now coming since COVID-19, and we now have all kinds of equity, diversity, and inclusion initiative across the country in research and even in clinical practice. I'm hoping that we're beginning to address those issues, which are now being named more explicitly, including structural racism, systemic racism, and all the levels of racism in our system. Did I answer your question?
Yes, yeah, I think so. Thank you for that context. I'm sure that's you know, a good lesson for those of us that are listening or watching from here in Canada. I'd like to just wrap up by asking each one of you for some closing remarks. Kiswahi, perhaps we can start with you and then head to Nancy and then Josephine with anything you'd like to add to the conversation to close. Oh, sorry, Kiswahi, you're on mute.
Sorry for that. I'd like to pass my gratitude. I am very much grateful to be part of this panel. And I'm grateful to this thing that you are talking about, because I like maternal health so much, in such a way that during my master's, my dissertation was on birth preparedness and emergency readiness. So it's just my soft spot. Thank you so much. That is all I can say.
Thank you, Kiswahi.
So as I would echo what Kiswahi just said, and it was great to be on the panel with you and to hear about your experiences. I would just leave with two final messages, I guess. So the first, as a nurse, I think, you know, working in Sierra Leone really taught me the importance of having that deeper social and cultural understanding of what's going on. And it is the community itself who lives the experiences every day that understands that. And we must hear from them, learn from them as we do our work, no matter where we are based. And as a grandmother, I'll just read a couple of sentences from my memoir. We need to feel the depths of human connections. Let these rouse your compassion, your humor, your love, your outrage, and your determination to better the human condition. I think we all have a role to play. Thanks.
Thank you, Nancy. Josephine?
Thank you, Nancy, for sharing this part of life with me. This is very different from the usual academic stuff.
Yes.
So I just want to say this speaks to the power of international collaboration, of exposing people globally to different lives. I think Nancy's story speaks to what is possible, even when you expose somebody with very limited experience to a very different culture, and how you can open people's eyes. And I am looking forward to our continuous collaboration with our colleagues, especially in low-income countries, as we hold hands together to address the whole maternal child issues and can create more of this kind of impact globally. So thank you for the opportunity.
Thank you so much, Josephine, and to all of our panelists for an incredibly insightful and engaging conversation. We're getting lots of messages in the chat with thank yous to you all. So appreciate your time and your insight and the stories and examples that you brought today. Just a brief, more housekeeping from us at the Stephen Lewis Foundation. A brief reminder that we have upcoming events going on here at the SLF. We will be celebrating Idahobit, the International Day Against Homophobia, Biphobia, and Transphobia on May 17th with a very engaging evening event that will be on May 17th. And during the last week of May, we're going to be hosting a week-long well-being event complete with yoga and meditation classes And you can get more information about both of these events by signing up to our newsletter. I think we're going to put that link in the chat. And, you know, or of course, signing up to our social media pages and following the Stephen Lewis Foundation there to get all the latest news. I want to thank all of our guests for the conversation again, and also thank you to our team. We have Sarah and Ruth Ann, and as well as Niambi, who read the land acknowledgement. Thank all of them for assisting us with pulling off this event. And thank you to everyone for joining us, of course, for this discussion. We hope you learned a lot. I know I did, about traditional birth attendance, maternal health, and about the importance of community-based solutions, which is a topic that's very close to us at the Stephen Lewis Foundation. And if you feel compelled to support our work and the work of our partners, like the Wellness Center run by the Eswatini Nurses Association in Manzini, where Kiswahi works, you can make a donation with ease by visiting StephenLewisFoundation.org, which was also in the chat. Again, very grateful to you all for joining and to our panelists, and have a lovely day further.